Imagine having, like, the most productive week of your entire life.
Oh, we'd all love that, right?
Right. But, I mean, you are sleeping maybe 3 hours a night, and you wake up feeling like you could literally run a marathon.
Just completely boundless energy.
Exactly. Your thoughts are crystal clear, you're churning through projects at work, your confidence is just through the roof, you feel entirely untouchable.
Yeah, you feel like a superhero.
So you wouldn't call a doctor, would you?
No, absolutely not.
You would probably just think you finally, hit your stride.
You'd think you're just crushing it at life.
Right. But what if I told you that this exact scenario, this feeling of absolute peak performance, is actually often the mask of a severe, potentially dangerous medical emergency?
It's a really terrifying reality for a lot of people.
It is. And welcome to today's deep dive. If you're joining us, you know we like to take complex subjects, strip away all the noise, and look at the actual mechanics of how things work.
And today is a big one.
Yeah, today our mission is grounded in a really fascinating clinical explainer from Coping and Healing Counseling, or CHC. We're unpacking the realities of bipolar disorder and the highly specific frameworks required for effective care.
It's such a critical subject to tackle because the gap between public perception and the clinical reality here is, well, it's massive.
Oh, totally.
We throw around psychiatric terminology so casually these days, right? And it really obscures the actual biological mechanisms at play.
That is the perfect place to start. We need to shatter a massive misconception right out of the gate here.
The mood swings myth.
Yes. In pop culture, and frankly just in casual conversation, bipolar has been reduced to a synonym for simple mood swings.
Right, like someone changes their mind or they have a grumpy afternoon after a good morning.
And the reaction is always, oh, they're acting so bipolar today.
Which is just so inaccurate.
Completely. We're going to completely dismantle that myth for you today. This condition is wildly complex, it's deeply physiological, and terrifyingly, it's frequently misdiagnosed.
Yeah, it has absolutely nothing to do with just having a fleeting moment of irritability.
Exactly. Okay, let's unpack this. If we're moving past the mood swings myth, we have to establish the clinical baseline.
Right, the actual diagnostic criteria.
Yeah, because I know you, listening, probably understand that bipolar involves highs and lows. But the clinical definitions are incredibly strict, dividing the condition mainly into type I and type 2.
And those distinctions matter a lot.
So let's look at bipolar I first.
Yeah.
The absolute requirement for a type I diagnosis is the presence of at least one manic episode.
Right.
But let's define what mania actually is, mechanically speaking.
Well, a manic episode isn't just, a burst of energy. Clinically, it requires 7 consecutive days or longer of an abnormally elevated or irritable mood.
7 full days. That's a long time to be elevating.
It is, and it's paired with a massive spike in goal-directed activity. The person experiences grandiosity, which is this vastly inflated sense of self-esteem.
Wait, to the point of delusion, right?
Exactly, and they have a distinctly decreased need for sleep.
And that's not insomnia, is it?
No, insomnia is where you want to sleep, but you can't. This is a physiological lack of need. They just don't feel tired.
Wow.
Plus, their thoughts are racing so fast it manifests as pressured speech-like. They physically cannot get the words out fast enough.
I've often heard this described as a car engine stuck in the red line.
That's a good way to picture it.
The accelerator is just pinned to the floor, the RPMs are maxed out, and the engine is absolutely screaming.
The car engine is a decent starting point to understand the velocity, yeah. But it misses the regulatory aspect.
Oh, yeah, how so?
Think of the brain's neurochemistry more like a complex HVAC system with a highly sensitive thermostat.
Okay, I'm following.
In a neurotypical brain, if your mood and energy start to elevate, say you get an exciting promotion, the system releases excitatory neurotransmitters like dopamine.
Right, you get that natural high.
Exactly. But the thermostat recognizes the room is getting too hot, and it kicks on a regulatory response to bring you back to baseline.
So it cools you down automatically.
Yes. But in a bipolar, the I-manic episode, that thermostat is completely broken.
Oh, wow.
The furnace is blasting, the temperature is at 120 degrees, and the brain has just lost the physiological mechanism to shut it off.
Which has to be incredibly dangerous.
It is. This leads to incredibly risky behavior, impaired judgment, and in severe cases, actual psychosis, where the brain breaks from reality.
So running at 120 degrees for 7 days straight, that causes incredible damage to the system.
Immense damage.
Now, let's pivot to bipolar II.
What's fascinating here is how the diagnostic criteria shift. which completely changes how the disorder presents to the outside world.
Because bipolar II doesn't involve full manic episodes, right?
Correct. Instead, it requires the presence of what we call hypomanic episodes.
Hypomania, meaning basically below mania. But I want to push back on that term a bit because calling it less severe makes it sound almost, I don't know, harmless.
Oh, it is a dangerous misnomer. Hypomania is less severe only in the sense that it doesn't typically result in psychosis or require immediate hospitalization. The clinical threshold is 4 consecutive days rather than 7.
But the symptoms are still there.
Oh, yeah. The decreased need for sleep, the racing thoughts, the intense productivity, they're all there, but the volume dial's at a 7 instead of a 10.
Got it.
But here is the critical distinction for bipolar II. These hypomanic episodes must be paired with periods of severe major depression.
So the defining characteristic of bipolar II is this massive pendulum swing.
Exactly.
A swing between the hypomania and these just crushing depressive crashes.
Yes. And because bipolar II is so intrinsically linked to those major depressive episodes, it sets up a massive hidden trap in the medical system.
A trap for when they finally try to get help.
Precisely.
I see where this is going. It comes back to the scenario we opened the show with, doesn't it?
Yep, the highly productive week.
When someone is in a hypomanic state, when their thermostat is running hot, but not quite blowing the house up, they feel
I
fantastic.
feel amazing.
They're getting praise at work. They have boundless energy. Their house is spotless. You don't walk into a doctor's office and say, "Doc, you have to help me. I feel like a superhero who only needs 4 hours of sleep."
You never report the high. I mean, it's human nature, right? You only report the crash.
Wow, yeah.
It's usually the depressive episodes that finally drive a person to seek treatment. The pendulum swings back, the dopamine and serotonin levels plummet.
The crash.
Right.
Yeah.
The exhaustion of the hypomanic phase catches up with them, and the depression becomes utterly unbearable.
So they finally make the appointment.
Yeah, they sit down across from a healthcare provider and describe an inability to get out of bed, pervasive sadness, and lethargy.
And the doctor, listening to this, doesn't hear anything about the hypomanic episode from 3 months ago.
Because the patient genuinely thought that was just a period where they were doing great.
Right. They just thought they had a good month.
Exactly. So the doctor hears symptoms of depression, and they diagnose unipolar depression, standard depression.
And that happens a lot.
This misdiagnosis happens constantly. Sometimes it delays a correct bipolar diagnosis for over a decade.
Over a decade. And considering roughly 2.8% of the adult population in the U.S. has bipolar disorder, the scale of this misdiagnosis is staggering.
It's a systemic issue.
So what does this all mean for the patient? If they just get a standard depression pill, doesn't that fix at least half the problem? I mean, they are currently sitting there suffering from severe depression, right?
It seems perfectly logical. You
Yeah.
treat depression with depression medication.
Right.
But the biological reality is terrifying. Treating a bipolar patient with a standard antidepressant like an SSRI without also administering a mood stabilizer is like throwing gasoline on a smoldering fire.
Throwing gasoline on a fire.
Yeah.
Let's break down the mechanics of why that happens. Why does an antidepressant act like gasoline in this specific brain?
We have to look at the synapse. An SSRI, a selective serotonin reuptake inhibitor, works by blocking the brain from reabsorbing serotonin.
So it's effectively flooding the brain with this mood-elevating chemical.
Right. Now, for someone with unipolar depression, this helps raise their baseline to a normal level.
Okay, that makes sense.
But remember our thermostat analogy.
The broken thermostat.
Yes. The bipolar brain has a broken regulatory thermostat. If you artificially flood a bipolar brain with serotonin, it doesn't just stop at normal.
Oh, no.
Because it lacks the mechanism to halt the upward trajectory, the antidepressant acts as a catalyst.
It launches them upward.
It launches the brain straight out of depression, past baseline, and directly into an active, severe manic or hypomanic overdrive.
Wow. So the very pill they took to stop the suffering actively destabilizes their neural chemistry further.
Yes.
Instead of fixing the problem, the medical intervention triggers the exact manic episode the brain was trying to recover from.
It induces a rapid cycling state. It is a catastrophic outcome for the patient's stability.
That is a staggering realization. You finally muster the courage to ask for help, you follow the doctor's orders, and your condition physically worsens.
Which highlights why getting the diagnosis right isn't just about administrative accuracy.
It's a fundamental matter of patient safety.
Exactly.
Which brings us to the treatment protocols outlined in the CHC Clinical Explainer. Because the stakes are this high, treating bipolar disorder requires a mandatory two-pronged approach.
The clinical consensus is that you cannot manage this condition with a single tool.
You need a system.
Right. We can visualize this as a two-pillar protocol, and both pillars must bear the weight equally.
Let's walk through Pillar 1 because the management of the disorder obviously has to start at the biological level.
Pillar 1 is medication, but it's highly specialized. It requires a psychiatric provider who deeply understands mood disorders.
So not just a general practitioner handing out SSRIs.
No, definitely not. We aren't looking at standard antidepressants. The source highlights the use of mood stabilizers like lithium or lamotrigine, as well as atypical antipsychotics.
Let's pause on atypical antipsychotics for a moment because that is a heavy, intimidating phrase for someone newly diagnosed.
It definitely is.
What makes them atypical and how are they working here?
Well, older typical antipsychotics essentially worked by hammering dopamine receptors shut, which caused a lot of severe side effects.
Like really blunting the person's personality.
Yes. The atypical generation is far more nuanced. They don't just block receptors, they modulate them.
Delete them how?
They act as serotonin dopamine antagonists. In plain terms, they act as the missing thermostat we talked about earlier.
Oh, that makes perfect sense.
Right. If dopamine is running too high-threatening mania, they dial it down. But they also interact with serotonin receptors to prevent the floor from falling out into severe depression.
Wow.
Along with drugs like lithium, which actually provide neuroprotective effects to the brain's gray matter over time, these medications create a chemical ceiling and a chemical floor.
So they forcibly narrow the corridor that the patient's mood can travel in.
Precisely.
But you mentioned this is only Pillar 1. Here's where it gets really interesting.
Yeah.
Because in a lot of other mental health discussions, you'll hear debates about whether someone needs medication or therapy.
True.
Like with mild anxiety or situational depression, therapy alone is often entirely sufficient. But the golden rule here is unambiguous.
The golden rule is that for bipolar disorder, therapy alone is completely inadequate, and medication alone is incomplete.
They have to go together.
Always. Pillar 2 is targeted, evidence-based psychotherapy.
And the CHC explainer is very specific about the types of therapy. We aren't just talking about lying on a couch and venting about your week, right?
It's far from it. The required modalities are highly structured. Cognitive behavioral therapy, or CBT, is crucial because it helps the patient identify the earliest cognitive warning signs of a mood shift.
So they can intervene early.
Exactly, allowing them to intervene before a full episode hits. But even more fascinating is a modality mentioned in the Source Interpersonal and Social Rhythm Therapy, or IPSRT.
Social rhythms. How does a social rhythm prevent a manic episode?
It comes back to biology. Bipolar brains are exquisitely sensitive to circadian rhythm disruptions.
Really?
Yes, a single night of poor sleep or a major shift in a daily routine can actually trigger a neurochemical cascade leading to mania.
That's wild. Just one bad night of sleep.
Yes. IPSRT focuses on hyperstabilizing the patient's daily routines. When they sleep, when they wake, when they eat, when they interact with others.
So creating a rigid external structure.
By anchoring the behavioral routine, it physically anchors the biological clock, drastically reducing the occurrence of episodes.
That is brilliant.
They also highlight family-focused therapy, which is vital because a manic episode doesn't just affect the brain, it often leaves a wake of damaged relationships, financial strain, and family trauma that requires systemic healing.
If we look at the reality of implementing all of this, if you are a patient, you are now managing a highly complex biological condition, and your prescription is essentially to build an entire medical infrastructure around yourself.
If we connect this to the bigger picture, the burden we place on the patient is monumental. It's massive. We are asking someone whose executive function is already compromised by severe depression or mania to essentially become their own general contractor for their healthcare.
Right, because you have to find a psychiatrist for the complex mood stabilizers. Then you have to go out and find a totally separate specialized therapist for the TBT or the IPSRT.
And ensure they're taking new patients.
And then you have to figure out if they take your insurance. And the worst part, these two providers probably work in different clinics on completely different electronic record systems, and they never actually speak to each other.
Which brings us to the danger of fragmented care. If the therapist sees the patient starting to accelerate into hypomania, but has no way to easily contact the prescribing psychiatrist to adjust the medication ceiling.
The whole two-pillar system collapses.
Exactly. It falls apart.
This fragmented logistical nightmare is exactly why dedicated practices like coping and healing counseling CHC are so vital to look at. They aren't just providing a service, they're attempting to solve the systemic breakdown of mental health care delivery.
The model outlined in our sources shows a practice entirely built around bridging this gap. We really should examine how they are structuring this access, because it's a blueprint for effective management.
First, let's look at the delivery mechanism. CHC operates as a 100% telehealth, HIPAA-compliant therapy practice.
Which is huge.
Now, I know telehealth is everywhere post-2020, but for this specific patient population, it is a clinical necessity, not just a convenience.
Think about the depressive pole of Bipolar II. When a patient is in the depths of a major depressive episode, simply getting out of bed, getting dressed, and driving 30 minutes to a clinic can be an insurmountable physical barrier.
It's just not going to happen.
Telehealth removes the friction. By bringing the clinic to the smartphone or laptop, adherence to that vital second pillar of therapy skyrockets.
And because they are fully digital, they serve all 159 counties in Georgia.
That geographic reach is so important.
I want to highlight why that matters systemically for a second. If you live in downtown Atlanta, you might have 50 specialists within a 5-mile radius.
Right, plenty of options.
But if you live in a deeply rural county, you might have 0. By blanketing the entire state, your zip code no longer dictates your access to specialized care.
The clinical team structure is also crucial here. CHC employs a diverse, culturally competent team of over 15 licensed therapists.
So they have the staff to handle the load.
Yeah, and this includes licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists.
Which maps perfectly onto the types of therapy we discussed. Need CBT to recognize cognitive distortions. They have that.
Exactly.
They need family-focused therapy to rebuild the support network. Marriage and family therapists cover that. And they don't just treat adults, do they?
No, they see teenagers from age 13 up. And they deal with a broad spectrum of issues beyond bipolar anxiety, trauma, PTSD, grief, and general life coaching.
But the true systemic fix, the way they actually solve the collapsing two-pillar problem, is their integrated care approach.
Yes. CHC actively coordinates with prescribing providers.
I am so glad you emphasized that. The patient is no longer playing a high-stakes game of telephone between their therapist and their psychiatrist.
It takes the burden completely off the patient.
The professionals coordinate the care behind the scenes. If the therapist notices a sleep disruption that hints at impending mania, they can immediately flag the prescriber. The pillars are actually supporting the same structure.
It creates a closed loop of care, which is the gold standard for mood disorders. But we also have to address the final barrier, which is often the most insurmountable.
The cost.
The financial reality of this level of care.
The financial details provided in the source are, frankly, a rare piece of good news in the modern healthcare landscape.
It's usually pretty grim, yeah.
Mental health care is notoriously expensive, and out-of-network costs usually sink a patient's ability to maintain therapy. But CHC has integrated deeply with major insurance networks.
This part is amazing.
For patients on Medicaid, the copay is $0.
Wow.
Let that sink in. $0 to access specialized mental health care.
And for commercial plans, the integration is equally robust. They accept major carriers like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana.
So most of the big ones. And the out-of-pocket costs for those major commercial insurances range from just $0 to $40 a session.
That's incredibly accessible.
They have systematically dismantled the physical barrier with telehealth, the coordination barrier with integrated care, and the financial barrier with deep insurance integration.
It is a model meticulously designed for actual patient compliance, which, as we've established, is the only way to keep a bipolar patient out of the hospital and functioning well in their daily life.
Exactly. If you are listening to this in Georgia, or if you know someone who has been trapped in that cycle of misdiagnosis and fragmented care, this is actionable information.
Absolutely.
You can reach CHC directly by calling 404-832-0102. Their website is CHL102. Their website is CHL102. And you can email them at support@cheechsholotherapy.com. I highly suggest noting that down. Once again, the phone number is 404-832-0102.
Having a centralized, highly coordinated care team isn't a luxury when dealing with this disorder. It is the fundamental requirement for stability.
It really is. So what does this all mean? Let's synthesize the journey we've taken today for you, the learner.
We've covered a lot of ground.
We really did. We started by tearing down the pop culture myth of simple mood swings, revealing the mechanical reality of broken neurological thermostats and soaring neurotransmitter levels.
Right.
We explored the rigid clinical differences between the full mania of type 1 and the hypomania of type 2. We exposed the massive systemic danger of the misdiagnosis trap, how treating unseen bipolar disorder with standard antidepressants can literally pour gasoline on the brain's chemistry.
Such a crucial point.
We established that safety demands a strict two-pillar approach. Mood-modulating medication handled by a psychiatrist, perfectly balanced with targeted structural therapy. And finally, we looked at how modern integrated telehealth models like CHC are actually fixing the fragmented care system by making this complex web of treatment accessible and affordable.
This raises an important question.
Ooh, what's that?
We spent a lot of time discussing how depressive episodes are the primary reason people finally seek treatment, because the hypomanic highs feel so incredibly productive and rewarding to the individual.
Right, they feel like they're just crushing it.
But we have to look outward at the environment we all operate in. How many people in our fast-paced, hyper-competitive society might be silently masking a clinical hypomanic episode right now?
That's a chilling thought.
Yeah.
Because they aren't just masking it to themselves, society is actively cheering them on.
Exactly. Our culture heavily rewards the exact clinical symptoms of a hypomanic state.
The long hours, the lack of sleep.
Think about the tech founders who sleep 3 hours a night. The employees praised for their boundless energy, the sheer grandiosity we demand from leaders and entrepreneurs.
Wow, yeah. We applaud these traits.
We write articles about their morning routines. We have built an economy that routinely extracts value from people in elevated states.
That is so true.
How many individuals are suffering in total silence through crushing, life-threatening depressive crashes simply because society gave them a standing ovation for their dangerous hypomanic highs?
That is a profound paradigm-shifting thought to leave on. We open this deep dive pointing out that pop culture minimizes the disorder by casually calling people bipolar.
Right.
But perhaps the much darker, much more dangerous reality is that our culture doesn't just misunderstand the mood swings, it actively celebrates and commodifies the mania.
Exactly.
It'll completely change the way you look at the hustle culture around you and maybe even the way you evaluate your own drive. Thank you so much for joining us on this deep dive. We always appreciate getting to learn alongside you and unpacking the invisible mechanisms that shape our world. Until next time, stay curious and take care of yourselves.